in.
Yes.
And they are very friendly. They respect you guys and they are very friendly.
Live आ गया है sir.
Sir, I think we are on live, sir.
Okay.
Yeah, just a minute. Wait for Sandeep to let us know.
We are live, sir.
Friends, welcome to Indian Arthroscopy Society Basic Arthroscopy Teaching Initiative. We are now on 93rd webinar, and on the Basic Arthroscopy series, it is number 17. Arthroscopic shoulder instability surgery is something which new arthroscopy surgeons are now delving into it. Dr. Sanjay Trivedi from Ahmedabad, Gujarat is going to give an overview about technical steps, how exactly to do step-by-step a Bankart repair. We are also joined by Dr. Menon from Kerala and Dr. Sridhar from Vizag, Andhra Pradesh, so as to moderate as panelists in this discussion. It's a very, very informal discussion where Sanjay is going to take us step by step into arthroscopic Bankart repair techniques. And we will have a panel consisting of Dr. Menon, Dr. Sridhar, Dr. Ranjit, Dr. Samanta, and Dr. Sandeep, Biraris, and Pradip, who are joining in and asking questions in between. I think this format has been very, very successful. We also get a lot of questions on chat box, which we forward to panelists, and they would initiate discussions. So best of luck for excellent education learning today evening. And thank you, Sanjay, for accepting the invite. And thank you, Dr. Menon and Sridhar, for accepting to be the panelist. Samanta, some words, and then we go to...
Yes. This is basically Sanjay is a very old friend of us, and he is one of the pioneers in the, not even only the state of Gujarat, but he's a pioneer also. He's very keen to teach throughout the country.
Yeah.
So it is an honor from the whole IAS team that Sanjay has taken our invitation. And also we feel honored that Dr. Menon and my younger brother, Dr. Sridhar, is also there. So whole EC team, also Ranjit and one senior member, you will be astonished that Dhaval Bhai has also joined for this meeting. So I also welcome Dhaval Bhai. So it's all yours, Dr. Sanjay and Dr. Menon and Dr. Sridhar.
Thank you very much, Samanta, to introduce me so eloquently. Thank you very much, Indian Arthroscopic Society, for giving me this opportunity to share my experience of Bankart's repair. Basically, Indian arthroscopy has grown leaps and bounds, and the conferences were abundant even before the COVID era. Now in COVID era, I think IAS is the highest webinar organizer in all over across the educational institute, at least in the orthopedic arena. Basic Bankart's repair, that is my brief. I have kept this as a very, very basic and reproducible kind of steps. This is how I started doing it. When I was looking to prepare this presentation, at that time, I was just searching my backup, that what is the available, what would be the best suited for this presentation video, which kind of video. Then I came across one of my live recorded surgery in one of the local conferences before 6-7 years. And when I went through that whole recording, I realized that this is the perfect material for a step-by-step Bankart's repair, how we do it in live surgery. This was done in the state forum, so it was meant to be for the initial arthroscopy surgeon who were graduating from knee to shoulder scopy. So this is the perfect presentation in my mind. As this is informal kind of chatting, my panelists are welcome to interrupt, stop, and ask questions and ask for explanation for the benefit of the viewers who are listening over the YouTube. So let us start this. I will just move forward my slide. My laptop is slightly playing up, and I'm waiting for a slide to move forward. Just bear with me. So the Bankart's repair is probably most commonly done in the lateral position by most of us. Very few of us are doing Bankart's repair is in B chair position. The simple fact that you can address posterior pathologies in the posterior labral pathology in the Bankart repair, which is associated with the recurrent dislocation, effectively in lateral position, easily in lateral position. And that is why I do my cuff repairs in the B chair position. However, I do my all instability surgeries in lateral position. So these are the basic steps of the Bankart's repair. It is positioning the patient. Proper positioning is very important. We'll come to that. Then you introduce your scope. Then you do diagnostic arthroscopy round. Then you take access into the joint by inserting a couple of cannulas. Then as soon as you have your cannulas in, you define and evaluate your labral, capsular-labral lesion, followed by mobilizing it to where you want to bring it and fix it. Refreshen the glenoid edge so that there is a bleeding bone. As for any orthopedic principle, you need bleeding area of bone to fix any soft tissue on top of it. Then use anchors. Then you do retensioning of the inferior glenohumeral ligament. And at the end, you realize that you've done good bumper effect, and that is satisfactory Bankart's repair. So lateral position, I use this kind of vacuum bag and position. You have to position patient 45-degree incline backwards so that your glenoid becomes horizontal, so that you can easily orient yourself in the views. I prefer general anesthesia along with the interscalene. My anesthetist sits at the foot level, and that is why I have a kind of instructed my anesthetist to use a long tube so that I have access all around to the patient. Whenever I want to use my anterior portals, I can just come to the head end, and then I can use it very freely. I always use two diagonally opposite viewing monitors so that I don't have to really turn and twist my neck when I'm working from anterior part. So,
and there's a
yes, sir.
Sanjay sir, will you be tilting the patient, or will you be tilting the table at 30 to 45 degrees?
See, what I do basically is I tilt the patient under this vacuum suck bag, so that I can position my patient in a fixed way. When sometimes you are tilting the patient, it is also one of the ways to do it. But then your bolster or support, sometimes they move and they create a little bit of problem.
Okay.
My personal opinion, but you can always do that.
Thank you.
And secondly, I use this bolster in the impervious cover, which I stick in between, in the axilla, in between arm and the chest. And when I want to use, open my inferior recess, bolster is just pushed inside and arm is levered on top of that, so that inferior axillary recess opens up. If you, I have this arm holder which I'm using it, but it is more commonly used in my surgeries these days for the tough repair rather than the instability surgery. One reason is that sometimes I give excessive traction on this, so I have stopped using this. I never had any mishap, but this is also one of the options to do it in the lateral position. My slide is not moving. I'm stuck slightly. Yes. So the first and foremost, when you position paint drap, I always draw my landmarks where you find out the, your acromion margins, posterior margin, posterior acromion angle, anterior acromion angle, coracoid process. You mark your coracoid process, because anything medial to coracoid process is not required here. You mark your AC joint, and then one thumb breadth medial and distal, that is where you go and put your posterior beam portal. Interior portals are in the line of anterolateral angle of the acromion, and then you have to go inferiorly to your anterosuperior portal and mark your mid-glenoid portal. And both the portals are sometimes very close, in a small patient, very close to the coracoid process, yet lateral to the coracoid process, not medially. Next step is to take just a skin incision at your marked portion. I do not use my stab knife right inside in the joint and cut the capsule, but I would use just generous skin incision, and then take my this blunt obturator sheath. I put my index finger onto the coracoid process, and I feel the head of the humerus on the top, glenoid on the bottom, and go in between towards the coracoid process, so that I'm not lost and I'm directly into the joint. Once you are into the joint, before inflating the joint, you should confirm that you are into the joint before putting the water inside. And this is very important when you are doing it in initial stages, because if you inflate or if you use your fluid pump before you confirm you are in the joint, sometimes this fluid percolates into the soft tissue muscle plane, and then subsequent attempts for the joint penetration becomes a little bit difficult.
Yeah, Sanjay sir.
Yes.
Just one question. Just for the sake of beginners, like, do you directly suggest going inside with the scope, or inflating with the spinal needle, inflating some fluid before?
I have actually never.
For the early years.
Yeah, I have never done that, but it has been described. I have come across this suggestion, but I feel comfortable, directly going into the beginning, and that is how I was trained, and that is how I have been doing. But if
yeah, sir. But for the beginners, sir, since it's a basic,
you can always use that. Yeah. But then you don't know whether you are in the joint, fluid. It takes good 10-15 minutes before you confirm that you're in the joint or somewhere else.
Yeah.
Because an intra-articular injection for hydrodilation, we suggest that we should go for the ultrasound guided injections. So
right.
So different in this situation, that it is difficult to put needle. Rather than a big cannula, you will really get a feeling of give way, and you will know that you are in the joint. If you get a bony resistance as an orthopedic surgeon, you know when to, actually stop and just, do not force your way into the bony landmarks like head of the humerus and the glenoid.
And the main thing maybe keeping our middle finger over the coracoid, and make sure that our scope or flocker goes directly to the coracoid, not
that is what
medial.
That I keep my index onto the coracoid so that I have my trajectory where to go.
Trajectory.
That is why you are marking the coracoid process.
Coracoid process, right? Can answer. Yeah.
So once you go inside the joint, again.
Can I speak about that injection, Sanjay, if you don't mind?
Please.
Yeah. So what I do in my clinical practice, I inject air.
Right.
Instead of fluid, what I do is I take around 20 cc or 50 cc syringe, and take a long spinal needle, and then go very close as we are going to push our sheath and cannula. So go in the same plane and inject air in the joint. So what it does is practically when I put my sheath, it gives me a hiss sound. More confirmation. And secondly, it adds to my diagnostic round. Because what it does is air inflates the joint, and then when I'm doing arthroscopy, I can do a very good real diagnostic rather than the fluid related diagnostic round. So
I agree.
Just a small suggestion.
That's a good suggestion. So once you have you are confirmed that you are in the joint, you have started your water, you immediately locate your long head of biceps. That is very important, so that you know where exactly your head is. And then on top your humeral head, down is your glenoid, and then you go and have a look at your lesion directly in the front of the scope. And this is how you this is
you need to mute someone. Mukesh Chug, you need to mute yourself.
So, you need to locate your labral lesion. Then You go beyond in the axillary recess. You come from the axillary recess. You can see here, I'm tilting my scope directly up, and I'm just trying to look for any Hill-Sachs lesion. And from there, you can move your scope cephalic way, and you can see the bare area. You can see this insertion of supraspinatus and then infraspinatus. So you need, at the beginning of your arthroscopy, you need to take certain decisions in today's days and time, whether you are going to do remplissage or not. So you need to define your Hill-Sachs lesion, whether it is in the need of the remplissage addition, because remplissage you have to perform before really you do anything anteriorly. You pass your sutures, but you do not tie them until and unless you have fixed your Bankart lesion.
So Sanjay, is the decision of remplissage during your arthroscopy surgery or before?
Most likely it is before the surgery, but there are some borderline cases which you need to, take that call on table.
So do you, when you have a scope in the shoulder, do you sometimes take the arm out of traction and probably try to see where it engages the Hill-Sachs? Is it engaging or a non-engaging kind of Hill-Sachs?
No, I do not do that actually.
Okay. Okay.
I do not do that actually. I take most of my decisions before the surgery, but in borderline Hill-Sachs lesion, I just want to have a look how, medial that Hill-Sachs lesion is, how closer to the articular cartilage. Even if it is sometimes small lesion, but it is closer to the articular cartilage where I can imagine that it will engage, early. I like to put my, infraspinatus into it so that, I can improve a little bit of redistribution. So after the diagnostic round, next you start your taking your portal, and this is the first portal I take is anterosuperior portal, just in the line of your anterior acromion point. And my trajectory, I try to be little bit of horizontal rather than coming from the top, so that I can visualize right to the inferior recess, and my reach is always there whenever I'm trying to use anterosuperior portal as a working portal. I use needle directly, but if you're difficulty, you can use your index finger with your scope looking towards just in the front of the biceps tendon, and you can palpate and push your finger, and you can very well see where you are making indentation, and use that spot to pass your needle and confirm trajectory of the needle, whether it is anterior to the biceps, it is not going through the supraspinatus or what we call as a cable.
Sanjay sir, can I ask something?
Yes.
So will you prefer going anterior to biceps or posterior to biceps, or any
I always take my portal anterior to the biceps, but whenever I want to park my cannula posterior to the biceps, I can easily do that from the same portal.
Or will you go for the superior portal first or the under inferior, or any?
I always go for anterosuperior portal first. That has been my routine.
Sanjay.
Yes.
This is Dr. Samanta.
Yes.
So you just, whenever you take the anterior portal, you first take the anterosuperior portal or anteroinferior?
Sir, I always take anterosuperior portal because I just want to have my access. This is, as you can observe here, it is very close to the, biceps here in the front, right? Yeah. And then trajectory of my anterior-inferior or mid-glenar portal is in such a way that in the rotator interval, my cannulas are merging, but they are divergent on the outside. So it gives me ample room to, visualize from anterosuperior portal and then work from the mid-glenar portal.
But do you find in some shoulder, if you put this 1 8mm and 1 7mm cannula in this rotator interval, do you feel there is some crowding of the things, and you are too parallel because your instruments and this thing has completely been parallel and handling the things because if you are converging inside, then probably your handling the instruments might be easy take. What's your opinion on that?
Yes. So it so happens that when there are small shoulders, especially in a small female, I just use this single cannula.
Okay.
Right. So that is a solution to that. But at times, whenever I can put this, this was a reasonably well-built guy, and I was sure that I will be able to use that, two portals. So, but since this is a formal step-by-step thing, we should encourage people to take two portals.
Okay.
And beginners can use mid-glenar portal by putting a Vissinger rod from the posterior portal and taking it out on the anterior side, and then outside in kind of rail loading portal. But more often than not, when I learned that in the very beginning, I ended up occupying whole of my rotator interval, and there was no space for my anterosuperior portal. So I struggle in that way. So I started habit of taking anterosuperior portal first. And since then I have been very comfortable. But whatever way, one can figure out, it is perfect.
Sanjay,
I always take a generous skin incision to put my 5 or 5.5 mm, and then I use my Vissinger rod to pierce the capsule inside, because more often than not, these guys are hyperlax. So if you go blindly, you have to pick your spot where to pierce with the Vissinger rod very carefully. Otherwise, your skin portal side may be correct, but inside you may end up more towards the mid-grade.
Sanjay.
Yes.
Your very one good friend, close friend has joined. That is Roshan is there. You can take his opinion.
Yes.
You can take his opinion. Roshan sir.
No,
sir, कुछ तो बताइए secret.
No need of opinion. We are all expert here.
Sir, he is everyone's friend.
And I have learned from Sanjay, I have learned from IPS, Swarnendu, everyone. And I'm very sure what Sanjay is telling is the right and truth. And practice makes man perfect. Initially, when you start learning it, start doing the arthroscopy, that overcrowding problem will be always there. We have seen it with the best of the best surgeon during live demonstration, where we have seen the placing those two cannulas on anteroinferior and anterosuperior cannulas. Just in the rotator interval is always difficult. But as you master the art, especially as Sanjay has already told you, that you take a long spinal needle and see the direction of your first portal, and then you decide about the overcrowding. My advice will be smaller advice. What I do is I always keep one needle, which I use two spinal needles, one which is going to anteroinferior portal, then another take needle, and then I make anterosuperior portal. Then I calculate my overcrowding distance externally as well as internally. So that gives me additional 1 minute time, but that gives me adequate information whether there will be a overcrowding inside the rotator interval or no. In case there is a overcrowding, what you should do is you should just shift your anterior inferior portal modes toward the subscapularis tendon. So that is a small tip.
Okay, Sanjay.
Yes. So I put my Vissinger rod, I penetrate the joint capsule, and then I usually dilate with my golden obturator, so that there is slightly bigger rent into the capsule over the Vissinger rod. And then I insert my 5 or 5.5 cannula. Here I'm using 5 mm cannula because this was the live demonstration for particular industry guy. And second step is to, once you put that, you see that my cannula is in the lateral view, it is slightly, it is going to be divergent. You can see that. And then I take again a needle. I always use the stellate of the intracath for this purpose. And then I look for the inserting that needle just on top of the subscapularis, which is here, which you can see. You see this triangle, rotator interval triangle, is really small, but the distance between these two, because for the mid-glenar, I try to come from down to little bit up, and that is how I can do my divergent placement of the needle and then cannula. So here I have parked my anterosuperior cannula slightly, on the top, and I have taken the knife, taken generous skin incision to put 8 or 8.5, depending upon what kind of suture passer you are using. Mostly it is 8.5 everybody uses. Then I take a Vissinger rod, I penetrate the capsule in such a way that I'm very close to the subscapularis tendon, and then on top of that, I put my cannula
Sanjay sir,
along with the inserter. You can see here there is hardly any space, as everybody has rightly pointed out, but putting 2 cannulas make your life much easier actually. And in difficult situation, I have started using without cannula anterosuperior portal, and instead of that, I put a cannula in the posterior portal. So my suture parking portal becomes a posterior portal, and permanent viewing portal becomes the anterosuperior portal. That's it. That is what I have figured out at times when I am in difficulty.
Sanjay sir, can I ask something?
Please.
Anytime have you gone through the subscapularis to get access to the inferior labrum?
So far, I have not found any need for that. As I told you, if I put just a Vissinger rod and my sheath on top of Vissinger rod, most of my surgery I do from anterior superior viewing portal. And then you can introduce your, small cannula 5.5 into the posterior portal, and you can shuttle your sutures from posterior, and you can easily get away by not using 5.5 cannula in anterior superior portal.
Sanjay, there is a question from Rosan.
I think there is a very well said point raised by Dr. Menon. At what time you go through subscap? I have gone through subscap intentionally many times, especially when I want to do the bony Bankart repair. Sometimes it's very difficult to get that trajectory and your anchor very parallel to the glenoid and in the near the crater of the fracture. So it is very difficult. In those situations, what Sanjay has already told you, go capsular, then go through the substance of the tendon of the substance of subscapularis, and you can create a portal, virtual portal, or you can create a just anchor placement through that portal, through the subscapularis. But again, you have to take out the threads from the subscapularis, and then you do your articular work as through intracapsular work as described during the Bankart repair. So there is a role. There is a role for
5 o'clock portal or 5 o'clock portals are actually very rare.
And yeah, it's a very rare. It's a very rare.
These are for very special situation, and my dear friend Rosan has mentioned. And probably
Swarnendu, those special situation could be the first situation you are facing in your arthroscopic practice.
Okay.
So at least
Sanjay is telling only on the basic things. So we'll be coming to that later.
No, but that is a valid point, and I take that point.
Yeah, that is a valid point. Yeah,
because you have to go far, medial on the glenoid if you want to put an anchor there and fix a bony Bankart there. So he's right that you can go, behind the tendinous portion. You have to pierce very gently, but not at the leading edge of the subscapularis, I would say.
And the one downside is if we go through the subscapularis, the high chance of axillary nerve injury. Is it correct, sir? Chances of
I don't think so.
In fact, nowadays, if you see the arthroscopic Bankart repair, there is a European group which has come up with a subscapularis tenodesis technique.
Yes,
where they describe, it's called ASH technique, arthroscopic subscapularis anterior tenodesis for the instability, and it is a very, very popular surgery. In fact, if you go to the Eastern European countries as well as the mid-European countries, all this Switzerland, Norway, they do a lot of arthroscopic subscapularis tenodesis for a recurrent dislocation of shoulder where you have a situation where you don't have a great labral quality. So
basically this is for when the capsular lab quality is poor, and also they are doing it for the hyperlax patients.
Not the primary procedure, sir.
This is not primary. Yeah,
it's not a primary procedure, not at all.
I think Sanjay, let's just stick to the primary basic steps.
Yes, let us do that. Okay, IPS, thank you. So yeah, so I'm showing here to my audience that after putting 2 cannulas, what you can see is my cannulas are divergent. And, there will be a close-up view now into this. And you can see that, while I'm using my instrument through the mid-glenoid portal or suture settler or spectrum through my mid-glenoid portal, it's not going to hurt me. Even when I'm using viewing portal, this anterosuperior portal. So that was the point I was making here in this video. And I have moved to next slide now. So let us... Okay, so first thing you do after the, putting the cannula, here I did in that there is some affliction of the bicep, which you can see here. where you can use your probe through the intersuperior portal, and you can just look for the slap also. This biceps anchor is quite mobile, and there is also fibrillation into this. And in this, I have not included video of tackling the biceps in this, but as this was the basic Bankart step-by-step repair. But as you can see, inside both the cannulas are sitting pretty side by side, and they are always in the rotator interval close by close. So you have to get used to working with two close by close cannula inside the joint, while you can have two divergent cannula outside the joint. So at this juncture, I take my scope out of the posterior portal. I put a Vissinger rod before I withdraw my this sheath from the posterior portal. So I have ready access of the posterior portal whenever I need to go back to the posterior portal with my scope. And then through the intersuperior portal, I will put my sheath and scope, so that now I'm looking on the top of the my capsulolabral region anteriorly, and I can start working there, just like that. This was the smaller cannula, and the industry sheath was slightly bigger, 6 mm, so I could not put my sheath there. So I just removed the sheath and use only telescope inside through this, and my inflow was from the posterior portal, where I reintroduced my sheath and continued with the surgery. But this can happen in this situation. So that is what I eventually did. But from anterosuperior portal, you can view all around by, very easily by manipulating your scope, top, bottom, right, left. And this is probably because my computer is slow. This is stopping, my video is stopping. But then what I did, I used my posterior portal sheath as an inflow and continued with the anterosuperior viewing portal. And now we are back in the business here. Now video has stopped because of the probably some slowness into my RAM. The last Windows 10 update has slowed my computer beyond my comprehension.
Yeah, that's the problems of Windows 10.
Yeah. So that is why we are getting this. Otherwise, this should have moved. Okay. So as you can see in the inside view, now what I have done is I put from posterior portal, the obturator, you can see my posterior portal is quite flush to the glenoid. And this is very important if you want to measure the, what you call the on-table bone loss or stuff. These days, we don't really do that. We always decide all the bone loss from the CT scan before we even take for the surgery. But this is a 6-7 years old video, and this was recommended. So this is the level, and this is how it is parallel to the floor. And I'm just trying to show that. Let's move to the next slide. So now I'm looking from the top, and I'm evaluating my labrum. And as soon as I turn my light cable, I can look down right into the valley. And this is the labrum along with the anterior band of inferior glenohumeral ligament there. And this is the glenoid, and this is my mid-glenoid portal, which is right on the top. So when you visualize this whole thing, this is your anterior band of inferior glenohumeral ligament. What we could not see in the previous slide, that I viewed a posterior portal. I also checked the posterior band of inferior glenohumeral ligament, and I also reviewed the posterior labrum, but we could not see that on the clip. Then first thing you do is you check that how firmly this labrum is stuck, where it is coming, and how much and how far you are going to liberate it. In whole of this instability surgery, especially in Bankart's repair, the mobilization of the capsulolabral complex is the most important step, and that will only this step will decide the success of your surgery. Putting an anchor, tying a knot, passing suture, these are just mechanical things. How well you mobilize it, how adequately you mobilize this capsulohumeral complex is directly, affecting your outcome.
So what are the instruments you use to elevate the labrum? Any special instruments?
So all the sets have curved and straight liberator, like you can see here. And it is very important to use the sharp, little bit sharper one rather than a blunt. And gently make your way. At times you can use mallet, but most of the time with gentle and patient nudging of the capsulohumeral complex, you can always do that. And this is 6-7 years old video. I usually used to go up to 6 o'clock and not beyond that. And since you can see here, I have a very robust labrum here, and it has, I really don't need too much of the capsular shift here. So I did not really go right beyond 6 o'clock, but you can always use your scissors as you can cut and you can go beyond that. But I stopped at, just close to the 6 o'clock in this particular case.
And also, the end is like where you know when to stop deliberating. Any tips on it?
Right. So you need to check in between. You can pick up after you're liberated enough. You need to check with the grasper, grab your tissue, bring it up, and see, basically it is a south to north shift and east to west shift, right? So what you have to do is keep checking. When you think that your inferior glenohumeral ligament is adequately tight, you don't need to really do a lot of shifting. So when you pick up the tissue, you just need to have a look at your IGHL when it is available, anterior bend. And if you think that, okay, this is tight enough, and that is the end of your liberation. Here, this was a robust and very fine labrum, so I did not really have to do much. The next step you do is the glenoid preparation. Okay, again, this is stuck. Okay, it is started. Okay. So here, you can see I'm just trying to grab my labrum and trying to, check that whether I need to do anything beyond that or not. And as you can see, that anterior band is becoming tight in my grabber, and I was happy with that. So I did not go beyond that. Again, my video is stuck. I'm extremely sorry about this, but my laptop is playing games today. Like that. So once you are happy with your liberation, you can divert your attention towards the glenoid. And whatever bone you see is always covered with a fibrous tissue. And there is always a little bit of cartilage overhang onto the top. Again, it is stuck. Damn thing.
Sanjay sir, maybe in preparation of the glenoid, like we prepare it, or with a periosteal elevator, will we get a fresh pleat, something like that, or with a burr?
See, this is a kind of these liberators are kind of periosteal elevators only. Right?
Yes, sir. So our motto is to separate the labrum from it, or get us some fresh bleed so that we'll have a better healing.
Our goal is to get a bleeding fresh bone surface.
Yeah.
Where you can stick this soft tissue.
Correct. Yes.
That is our goal. And here, as you can see, the video didn't play, and my pointer is also stuck here. Okay.
Yeah.
This is trying to move. I don't know which way. So I also
use the arrow keys.
See my RAM. I can see here my hard disk. My RAM light is completely, stuck. So that there is not enough space for this video to run. That is what I can understand. This is the old version of laptop, and it had limited. I discarded this, but since my
No, we can Sanjay bhai, we can discuss in this length once it done is okay.
Yes,
Tell us the tricks how you go ahead.
Right. So once we liberate the capsulolabral complex, you divert your attention to the glenoid, and I always take a little bit of sliver of the cartilage from the glenoid, because I honestly believe that cartilage and soft tissue healing is impossible. So you need to have a little bit of margin here on top as well, not only in the side, but top as well, where you can put an anchor for the face, and then you can bring your capsulolabral complex there, and you can make that labrum heal on the surface like you normally see the labrum on top of the glenoid. So here I'm cleaning it. I'm satisfactorily clearing the debris. This debris cleaning is also very important, because sometimes you must have noticed that when your patient has a little bit of swelling, little bit of unexplained pain and warmth, it is because of this residual debris, and it invites continuous low-grade synovial effusion, and then patients are not happy, and it takes long time, 2 to 3 months, for that to resolve. So as for the knee surgery, where you clear your joint at the end of your ligament reconstruction, when you have done bony tunnels, it is equally important here to clear all your debris once you have dealt with your glenoid.
Yeah, Dr. Sanjay.
Yes, Ranjit.
Hello. Yeah, Ranjit. Yeah, do you take a ring curate and take out the cartilage maybe of 2 to 3 millimeter on the edge?
That is what is being seen here. Now that video did not run.
Okay.
But I always use a ring curate, and that is a sturdy one, because thin ring curate which we use for the knee scopy doesn't work here. Okay.
I think it's also important to identify where the interval lies between the labrum and the bone. Sometimes the labrum is stuck, and you actually put your elevator between the labrum and the capsule, and you detach the capsule rather than elevating it from the labrum.
That is very true, and that is why it is important to have a thinnest possible liberator.
Yeah.
And stay close, very close to the bone.
Yeah, close to the bone, and elevate it like we do it for periosteum elevator.
Sir, I think the trick is to stay close to the bone, as close as possible.
Yeah. The way you go away from the bone, then you are going into the capsule, and you're just tearing the capsule away.
Yeah, sometimes when the labral tear is extending a little bit more beyond 5 o'clock position, do you go from the posterior portal and clear, or how you do?
No, I don't go to the posterior portal, because there are curved liberators available. That is what you mean to ask, no?
Yes.
Yeah, and then you can use scissors also, and then that scissor can go right up to 6 and beyond 6 o'clock. Okay. See, to go to the 6 o'clock, your portal has to be having a correct trajectory. Too vertical doesn't work. So it has to be almost 35 to 45 degree angle, where you can go right beyond 6 o'clock, at least up to 6 o'clock.
See, Ranjit, you have to go release up to the more or less 6 o'clock position most of the time.
Yes.
Because if your portal is correct, if the anterior-inferior portal is very correct, it is not at all difficult to reach the 6 o'clock, because unless you go to the 6 o'clock, you cannot recreate the anterior limb of your inferior, the anterior limb of the IGHL. Understood?
Right.
So you have to release. Even there is, you see naked eyes that there is no tear.
You can take a concave curate.
Yes.
So that's not curate, liberator.
Liberated.
Yeah. And there are, to the right, to the left, there are 3 in any good company set. There are 3 liberators. One is straight, other is curved to the right, and another is curved to the left. And you can use gentle mallet tapping if you are afraid of doing a lot of using a lot of force and sudden give way and damaging the axillary nerve in 6 o'clock position. You can use scissors also in that scenario, where you are remaining close to the bone and still you are liberating the complex.
Sanjay, some surgeons use radio frequency also. So do you
Right. Yeah,
recommend
I
that?
agree. And I would prefer hook probe for that to just
Oh,
start.
okay. To develop the interval.
Yes, to develop the interval when it is really ill-defined.
Okay.
And same hook probe IPS can be used to clear a little bit of cartilage from the face, a millimeter or so.
Okay. Yeah, it helps.
But since this was a basic, I did not include that video because, I think for the step-by-step thing, you have to give reliable, reproducible, and safe things. That's what I thought.
Sanjay sir, if it is like any thin friable labral tissue, like what are the precautions or any tips to tackle that?
You have to pray to God that this is not going to slip. Okay.
So do you
Like especially when they are elevating,
As
any tips we take for?
So having said
Sridhar
that,
said, in such cases, do you add remplissage because that's going to add on your protect your repair?
I don't think poor anterior tissue will be helped in any way by remplissage.
Okay.
Okay.
I think there is a good point. Sridhar has raised a very good point. When you have a very small deficient labrum, see basically capsulolabral repair is the definition for Bankart. So what you can do is you can release it more so that you can give more and more capsule, and you can create a good amount of bundle along with the capsule. In that case, you can take a big deeper bite with the capsule so that you can get a bigger tissue.
Yes.
So sometimes even if your labrum is degenerated or is completely worn off, you can still get a good bumper effect when you're doing a repair if you take a good amount of healthy capsule. And for that, as Sanjay has already said, he goes up to 6 o'clock. But if you want a better capsule, I will like to go beyond 6:30 or even 7 o'clock. So that in that situation, you can get a big amount of capsule from the inferior part. So that you can do a short south to north shift.
Absolutely.
Exactly. Yes.
I think
so here I differ a little bit with my good friend Roshan. I believe that this is a hammock which is supporting the head of the humerus with anterior band and posterior band. So rather than going to the beyond 6 o'clock up to 7 o'clock, I would placate posterior band of the inferior glenohumeral ligament separately and support that hammock. That is what I believe. And more often than not, I add PIGHL whenever I have a very capacious, capsule. I have very large inferior recess. I find when on inspection, I do not see a very well formed posterior band of inferior glenohumeral ligament. Any thoughts on that?
In that case, Sanjay, how you judge your tension on both the AIGHL and the PIGHL?
I have one slide where I can show you that tension.
Okay.
Second last slide is about adding PIGHL to this.
Also, I think the misconception of creating a bumper actually creates misconception. You can just maybe create a bumper without creating a tension in the capsule behind. And as you rightly said, it's more of a capsulolabral mobilization which is more important.
True.
So, yeah.
So obliterating the deep space between the this capsulolabral is very important.
Yes.
So at the end of your Bankart's repair, you should not be able to go between these two very easily. That is a successful repair, isn't it?
Can I ask you something?
Please.
Yes.
Yeah, yes.
Particularly if the tissue quality is very poor, there has been school of thought that say you can include the MGHL. Maybe you lose some amount of external rotation. Any indication for that? Anytime you can include the MGHL in the...
It gives you mental satisfaction, my friend. But MGHL is not always present, number one. MGHL in Bankarts is not very well formed. Whenever you see it is always stretched out and thinned out. But yes, I would agree to the Roshan's idea of in those cases, I have never done that, but some subscapular is, incorporation. But MGHL, I don't think it is of so much of, help. But yes, it will give you satisfaction that you have got some tissue to take a bite on.
And is there any particular dimension of the bumper effect, you know, in like a 5 mm, 6 mm? What is any criteria?
No, there is no guide. There is no guideline that way. That Dr. Menon, whatever tissue you get and maximum bite you can take. As I completely agree with my friend Sanjay, that your mobilization is the main key. Whatever tissue bite you can take with your, I am not mentioning the instrument name of the company, with a special passing device, the retrograde one, that is the best one.
On lighter note,
And always remember the first stitch in the inferior pouch is the money stitch, because that is the 50% whole Bankart surgery. Rest two are 25 and 25. First stitch is the money stitch.
Yes.
Sanjay, anytime have you used an antegrade suture passer to actually take a bite?
I know one of my friends is smiling.
Retrograde, but do you take antegrade sometimes, because there are companies selling antegrade bites?
One of my dear friend is smiling. I can see that.
So IPS, I have seen that being used in the live surgery also, in the recording also, but so far I have not tried it. I have not used it, because I think that I can get by using this suture shuttle devices very well. I actually haven't felt any need to do that somehow.
Okay.
I think we must caution the juniors that if you use that instrument, there is a high chance of breakage of your needle, which frightens me from using that device for the classic Bankart repair. And it is a special situation where we use. I am not mentioning the special situation in this basic class.
Okay, so the next step is to put an anchor on the top, and this is the particular company anchor. So for any anchor insertion, you will have a cannula or what you call inserter or sheath or whatever, and it will have a hole at the top and some spikes to stabilize that on the face of the glenoid. You have to understand that right on the very much face and away from the glenoid edge, inside on the cartilage is not the right idea. Not too much onto the edge where your anchor fixation is in doubt. So you have to find out a critical balance. Normally, when I see good enough glenoid, my preferred position is 5 o'clock, 4 o'clock, and 3 o'clock for 3 anchors. If it is a smaller glenoid, I would go for 5:30, 4:30, and 3:30. Here I have put my anchor almost at 5 o'clock here, inferior anchor, because I see robust capsulolebular complex and good IGHL matching with this area. So I did that. There is a punch starter. Then it is followed by the threader, which this is a thread. And this particular industry, I was forced to use a metallic anchor at that point in time before 6-7 years. So I have used that, and you will see that, and it is a big size anchor. But fortunately, this glenoid size, patient size is big, and so I could use that. These days, I use smaller 1.4 or 1.9 millimeter anchors, and these days you also have all suture anchors.
Can you give some tips on the types of anchor? What is your personal preference, knotted, knotless, all suture, or?
Right, sure. So these days, I use mostly all suture anchors. I most of the time use single loaded anchor, not the double loaded anchors. And I use the curved inserter for the inferior most anchor and the straight ones for the other 4 o'clock and 3 o'clock or 4:30 or 3 o'clock anchors. I always love to tie knots. I somehow don't like to use knotless anchors because sometimes you are committed. I don't think it does save time, or once you do it well, time is really immaterial. You can equally fast do the knotted ones. So as you can see here, I'm here at 5 o'clock and not on the edge, on the face, and the hold of the anchor is really good. I always check my anchor by just trying to move my anchor. So if anchor is poorly fastened, it will immediately come out, and it will not come out after you have tied the knot. So it is very important to check each anchor after you insert it that they have been firmly fixed, especially all suture anchors, because all suture anchors have sometimes tendency to not get fixed well, especially in the inferior most portion. Then that is why when you use the curved inserter, chances of ill fixation of all suture anchors are very less.
Even if the tissue quality is a bit poor, will you go for the all suture anchor, or will you?
Which tissue quality?
The bone quality is not that. If it is not
I
that.
think in modern all suture anchors, and for the instability repair, I have no doubt that I can use all suture anchors in each and every patient. For tough all suture anchors, I would be very picky, and I will not commit before testing the bone.
Any reason why you're not preferring double-loaded ones, sir?
Okay, two things. You can use more number of anchor and do better fixation.
Right.
More often than not, double-loaded anchor has a single point of fixation, and you are putting too much stress on that single point of fixation, and you are not going south to north. So I don't see any point really in do that. That is why. And secondly, for the beginners, I must warn them that suture entanglement is very common with the double-loaded anchor.
Yeah.
Fair enough?
Yes, sir.
Okay. So once you do that, there comes the suture management. So this is the single loaded anchor. This was metallic anchor. And then all I do is manage the suture, pass through the tissue and tie a knot. So this is the time for me to move my scope to the posterior portal, and then my parking portal will become enterosuperior portal. So I will park my sutures. This is not moving again. So I used to keep on changing those things. These days, in today's days and time, when I do not really change my scope from enterosuperior to the posterior portal, because I can use posterior portal as a virtual cannula, and every time I can park my suture there and safely perform the procedure. So, these days I'm not doing that, but in this 6-7 years ago, this was a demonstration for the beginners. So I went into my posterior portal with my, okay, we have moved really ahead actually, and I'm trying to go back. And this laptop is really troubling. So let us discuss about preference of my panelists and my senior colleagues. How they use posterior portal as a parking for the sutures?
Sometimes we use posterior portal to pass in a tissue holding kind of thing, so that you are able to grasp the tissue and actually push it up.
I
so
totally
that when you are
agree.
taking a bite from the front, you are able to take a nice bite.
Sure.
Otherwise, the labrum is falling in the front, so you are unable to take a bite. So if you are able to go and hold and then shift it, then for basically capsule labral shifting.
Oberoi, so that way you can get both inferior to superior capsule.
Absolutely.
Shift.
Okay, same thing can be done by viewing posteriorly. Enterosuperior portal can be used to lift the tissue. You will have a view, and then you can lift, and then from midglenar portal you can take a bite.
Yes, absolutely.
So there are ways and means, and you start adding your expertise into gain your experience, and you will not be satisfied with bites. Are a serious most bite will decide the outcome of this. So here I'm using a kind of suture shuttle spectrum. This is a limited reuse, so I do not use it for more. As you can see here, my scope is in the posterior portal, and my suture I have retrieved into the anterior superior cannula. And here it is important to note that you have to start taking bite beyond the level where you have put your anchor, and that is the only way to ensure the shift. So it will become very clear from where I am taking my bite in a minute in this video. Right, you can see that I'm going right close to the 6 o'clock. There is anterior bend of inferior glenohumeral ligament. And then my anchor threads are actually behind my suture shuttle. There. And it is very important to take a very generous bite of this capsulolabral complex. Sometimes you tend to take a half of the capsulolabral complex, and then tension will be less. And I always use PDS as a passer because PDS #1 is a fantastic suture material and cheap to railroad this sutures. So once you do that, you retrieve this PDS with the retriever or grabber, take it out to the enterosuperior portal. You take your suture out of this pair of suture, the one which is towards the tissue, and tie a simple single knot and 1 or 2 inch piece of the suture, and then you can gently wiggle your spectrum out of the tissue, and along with that you railroad this suture from the tissue from enterosuperior cannula to the mid-lunar cannula. Here I am wiggling it out. So it is very important not to push it, pull it out. You have to, as you have taken a bite by rolling your wrist, you have to unroll your wrist so that it does not damage your capsulolabral complex. And once you have done that, you take your suture retriever. These days, for the inferior, I tend to take a mattress suture, but here I took a simple suture. In mattress, again, your desired site and take both the sutures to the capsulolabral complex, and then you tie a knot so that knot is always toward the tissue and never onto the bone. But here I did a simple suturing, and I retrieved my remaining suture to the my remaining anchor suture to the mid-glenoid, and now it is over to the knot tying. Now, when suture is sliding, you must define that which suture is coming out of the tissue and which one is at the anchor. And suture coming out of the tissue becomes your post because you want to take your knot onto the tissue side rather than to the bone side. Otherwise, there are high chances of chondral abrasions. So now I'm using a sliding locking knot, which is Nicky's knot, very simple and small knot, unlike a big size knot of SNC or other knots, but all knots are almost equal. They have to be sliding and they have to be locking. It is very important to have a knot pusher which is not very sharp, because Indian make knot pushers are sometimes very sharp and they tend to really create a problem there. Now here I did not use my eye stalk to pull this part of the tissue, keep it tense and then tie the knot. But these days I tend to do that in where the tissue quality is really flexible. Here the tissue quality was robust and I could get away without using that. And here you can see that anterior band is really, really tight here. Once you sit that knot right onto the tissue, you take the other free limb and you kind of lock the knot. So this is known as the sliding and locking knot. And now I have locked it. There are also other sliding knots which are not locking, and you have to tie a couple of half hitches to lock it. But this is a Nicky's knot, is a small size knot which slides and locks. And then you tie 3 alternative half hitches here, and that will complete your first anchor. As I told you before, this is the most important anchor and most important suture passage and most important point of fixation in the Bankart repair. 50% of your job is accomplished if you had a good bite and good tension in this anchor suture knots. And then you simply cut away the remaining suture.
So we will put all the anchors and then knot it one by one, or you put one anchor, knot it, and come to a second anchor. What's the order? What is your choice of?
I put one anchor, pass sutures, and then I use my another anchor. So I finish one anchor completely and then insert second anchor and third anchor.
Dr. Sanjay.
There are ways to do different things in a different way. Sometimes people use 4 o'clock anchor, the tying first, and then go and tie 5 o'clock anchor. I agree with that, but there are no actual, prospective studies which one is better than other or no. But with this, I have never regretted my technique. So I'm just sticking to this technique. Yes, Ranjit, you were trying to say something?
Yeah, Dr. Sanjay. Dr. Sanjay,
Yes,
what is the bailout if there is premature locking of the knot? Because already you have put the anchor at the proper place, and inadvertently there is premature locking of the knot.
So there is never a complete bailout in this situation. First thing you must understand that you must learn to tie good knots on a dry bone or outside the joint very well, right? Okay, but then there are all left to do is jugards. You can put another anchor at 4 o'clock and use that on anchor suture along with this prematurely tied knot sutures, and then you can mix and match them both. But it is always less than optimal fixation.
Yes.
Has anybody?
Ranjit, then it is a suboptimal fixation. If
Right,
there is a premature knot, forget about that suture and forget about the cost of that anchor. We have to redo it because you cannot compromise anyway on your fast anchor, which is at 5:30. Because I told you that is the money stitch.
That is why these days, when you use a smaller size anchors, 1.4 all suture anchors, you can overcome this mistake by not going too far away from your original site. Do you agree? This anchor was 3.2 millimeter anchor. Yes. You cannot really, do anything about it. The old generation anchors were unforgiving.
Also, Sanjay, you actually rightly pointed out that you must learn the knotting technique, which is actually a mixture of sliding and locking knot.
Yes.
So initially people were putting sliding knot and then were putting half hitches. But sometime at the moment you put half hitches, that sliding knot becomes loose.
Yeah.
So again, that loop security, which probably Ranjit is also trying to talk about, knot security and loop security, that loop becomes loose and the whole money stitch is gone.
So IPS, in all our basic arthroscopy IAS conducted courses, most of the delegates were happy with their Duncan's loop, but that is only sliding, not locking.
Yes, that's the important point.
Insisted them to learn a sliding and locking, and this is the benefit of that.
Because Duncan is easy, but it has got problems because it may tend to become loose the moment you are throwing half hitches over it.
And Ranjit, your question is probably arising out of this knot.
Yeah.
Yes. Because that is the problem. Unless you otherwise learn the knot technique, then it is difficult to perform the classic Bankart event.
Absolutely. Sanjay, any tips that your knot is always on to the capsule side, never onto the article side? Any tips how you do?
Yes. So one thing, you must select your post because your knot will always follow the post. So you give little bit of tug and decide. Before you decide your post, you select your post, which is the suture passing through the tissue. That is number one. Secondly, don't go all the way down to the tissue. So while you come closer to the tissue, take a moment and try with your knot pusher, try to take this knot away behind the, capsular, labrocapsular tissue or bump, and then you really push it hard in and then immediately lock it so that it will not spring back.
Yeah, I think that's a good idea. You have to park it and then slowly push it onto the side.
Exactly.
It doesn't bounce back.
Yes,
it doesn't bounce.
It will bounce back.
Yeah. Any suggestions on adjusting the tension on the tissue, sir?
Once you tie the knot, it is impossible to do that. But
no, before that.
Yeah, before that, as I told you, I have not included that slide, but you bring your knot just on top of your tissue, use your eye stalk through the intrasuperior cannula, grab the capsulolabral complex, with that lift and pull towards the head end and give it to your assistant to hold it firmly. Right. And then you tie the knot, and that is how you tighten the capsulolabral complex effectively and control the tension. Agree?
Yes, sir.
So Sanjay, minimum 3 anchors is what you recommend for all instability. Minimum.
Yes, I would, as far as possible, put 3 anchors. That is my recommendation.
Perfect.
Shall we move ahead?
Yeah, please.
Yes.
Okay.
Any
And this is the suture cutting. These are the open and closed suture cutters and this, that. But you can see the knot. It is a very small size knot, very snug knot. And then you simply cut it 2 millimeter tails. And that is also very important. Okay. So once you have tied the first knot, it is very important to pause and evaluate what you have done, where is your second anchor is going to go, and evaluate. So you can see here, my anterior band of inferior glenohumeral ligament is really tight. The space has been obliterated, and I feel that the humeral head is slightly centered. So this is the most important stitch of the whole surgery. And this will decide your, redislocation rate, probably, in my views. So as you can see, this is the reason why you should not put all anchors, at once and then, try to do one by one. Suture entanglement would be severe. And this first one anchor has really obliterated this bare space, as you can see here. And this is at the 5 o'clock, and then at 4 o'clock, and then at 3 o'clock, just in front of the subscapularis is my 3 o'clock. So this is a second anchor at the 4 o'clock. If we want to not repeat this step, I can skip this slide and we can discuss, better things. Or you can see this, again, it is the same process. You select your spot on the face. You provisionally, one more most important thing I can suggest is always surgeon holds this inserter cannula. Otherwise, your assistant may move it. Your assistant can punch, drill, tap, even put the anchor and rotate. But if you keep your position on the glenoid of this inserter cannula, it will be, disaster averted. Otherwise, you're drilled and your this inserter cannula moves and you lost the hole. That can happen in the initial stage.
So Sanjay, in these titanium anchors, there is a laser mark to tell you up to which place you have to insert.
Yes.
But do you actually recommend inserting a bit more to be on the safer side?
This is the question which it asked to the company guys. They told me, sir, there are 2 laser marks. One is the outside the cannula, one is the inside. You can use outside the cannula, and when laser marks hit your inserter cannula, top margin, you stop there. There is no need to go any further, because these anchors of good companies are designed in such a way that head will never protrude if you do that.
That is true, but you see, at the end of the day, the top of the anchor is in the soft cartilaginous kind of.
In the cartilaginous structure.
So it is slightly better, because we have seen a lot of patients coming with round anchors. So maybe put it a bit more down so that it goes well into.
Yeah, that would be a good suggestion for the people, because fortunately I did not use many of these metallic anchors. I have not had my share of this situation. In Gujarat, most of the people started using biodegradable pretty soon when shoulder became popular.
Maybe we can put in another way, like if you put a little deeper, is there any issue?
I don't
think people
see too much deeper as an issue that your thread may abrade and get cut.
Yeah.
So you have to balance it out.
Yes.
And that can happen with the bio anchor also. Don't put it too deeper.
Sanjay sir, can I ask something?
Please.
If you are planning to put 3 anchors, what is the position of the anchors? It will remain equidistant, or 2 of them will remain close together, or what's your like?
Right. So I hopefully, my wishful thinking is to put them at equidistance. 5 o'clock, 4 o'clock, 3 o'clock, or 5:30, 4:30, 3:30. And you should aim for that. So when you put your second anchor after inferiormost anchor, first you have to look for the site of your first anchor, and then you have to look for your subscapularis tendon, which is your last anchor, and then go in between. That is what you should do.
Sir, one more question. Is there any benefit like you put all the 3 anchors and then go for tying one after the other?
I have
Rather than
never
putting one
seen that.
thing.
I have never seen that being done. So I won't be able to really, answer that because I have never seen that being done.
No, Sridhar, I think it is not recommended to do like that because otherwise there will be suture tangling for the juniors. I think the best way is that what Sanjay
One
sir
after
is
the
telling,
other.
go sequentially, and so that you can do north to south and east to west shift. It is a 1 o'clock shift. It is not unidirectional. It is two-way shift, north to south and west to east. So it go sequentially and tie it, finish the DACAP job.
Right.
Okay, so now we are on the last anchor slide. Okay, so this was the third anchor, and I'm going to show you that I took a bite just in front of the subscapularis and brought that at the level of subscapularis. You see that? This is the subscapularis tendon, and then that bite is taken. And this is the second, the 4 o'clock anchor knot. And then when I came out, I came little superficial. So I again went back and then came right underneath it. And I was beyond the anchor and then repeated the same procedure. And then, after you had tied this in the same way, railroading, posterior viewing, anterosuperior parking, railroading from that, simple knotting, Nicky's knot, sliding locking, same steps are repeated.
Perfect.
So this
has
is
it happened to you sometimes that once you have put maybe 1 or 2 anchors and then you realize that probably your tension is not so great, so you are able to pass a suture passing device, you are able to take a bite again, and you feel like putting one more anchor, so which is the place now you're going to put an anchor?
So
or maybe shift to not less.
After 3 anchors?
2 maybe. 2. Your money, your 530 and your 430 have already
So let me share you a secret that in the financial crunch situation in certain patients, you try to put 2 anchors wide apart. So you put one inferior anchor 5 o'clock and straight go to 3 o'clock. And then you realize that you are not happy. So I have done that and put that anchor in between. I have used anchor, what you call very small size anchor and got away with it. But if you want to do that, you have to put that anchor between your second and third anchor.
Is there a bailout in such cases that you take a capsular bite, a capsular labral bite, and then use a knotless anchor and then put it at any position, maybe even at 2 o'clock?
Yeah, then that is true. You can do that. But I have no personal experience of that. If anybody can share their experience.
Yes, Sanjay, problem is that the basic thing that we are teaching the juniors that always try to put the anchor and the bite, never compromise on taking the bite of a beautiful bite on the capsulolabral complex.
Yeah.
Because if you take a small bite and you are happy that I am tying something, this is not ideal.
Exactly.
If you are not happy with the bite, let it be 10 times.
Yes.
But you take a big bite, whatever tissue you have mobilized, you take a big bite, there only your surgery will be successful. And if you try to manage that with a knotless anchor, putting in between 530 and 430, that is an adjustment job and that is a very, very inferior quality job. It is not going to succeed. The patient will come to you with a failure.
That may be a day one failure.
Yeah, I totally agree. And that is why I showed in this video that when it came out here, it came out little superficial. So I went back. You can see here. This is the capsular bite and then labral bite. I came superficial. So I did not like it. I went inside again. I came out. It was again superficial. So I went again third time and got the proper bite.
Yes.
As you can see here.
Yes.
It is very important. And here I am checking everything with my probe, and which is important to check. This is the subscapularis here. This is my 4 o'clock anchor, and this is the 5 o'clock anchor there, as you can see. And that I cannot go very easily now in this inferior ECS.
Also, Sanjay, the suture passing devices, there are some disposable ones and people tend to reuse them. Every day you're passing a suture passing device, they hit the glenoid surface. and the tip is no longer sharp. It becomes slightly bent. And then taking that money stitch is bad, because then you are not able to take a very, very good deep bite through it. So I think I always use probably a good quality suture passing device.
I totally agree.
For the first one.
I totally agree. And sometimes that tip is bent. So it is so blunt that you can dent on the capsule, but you cannot pierce it. And it is so frustrating to see that.
Yeah. It just pulls the capsule, but you cannot pierce it. You are just frustrated.
Cannot pierce it.
It is so frustrating.
Yeah.
So
and
that
more
is
than
why,
the bite, it.
That is why I would recommend, rather than the sharp tip, diamond tip. The suture passers are a little bit better, because they are supposed to be stronger, and it should be a single piece, not the welded one where it can break. The one which I am using here, if you use it for more than 3-4 times, it can break inside, because it is 2-piece. So this is not a great device, but I'm quite comfortable with that. I know when to really stop using that again, and then use it for only ACLs, so those tibial spine fixations, the old ones. And secondly, I have actually broken this tip of this particular suture passer, and then as a loose body removal, I have retrieved it also.
Yes, I think these are quite important tips. Beginners will learn from the experience of the faculty here.
Sanjay, is there any shoulder scorpion here?
That is what I have never used it. I have never tried it. I have never felt a need to use that. I'm quite happy with my wrist movement spectrum. So here I'm trying to show a Wilmington portal, which is sometimes additionally used for the posterior labral repair, posterior-inferior labral repair, and there you can take a needle, quite close to the acromion bone in front of your posterolateral portal, and then you can use this, as actually a small nick, not the actual big portal. Just pass your anchor introducer and fix your anchor. So this is also at times used in the actual practice, where you have a little bit of posterior labral tear. So this is where I come to my 2 penny worth about the posterior bend of the inferior glenohumeral ligament. I use it. There is some literature support to it. My experience, I am very happy about it. When clinically I feel that along with the anterior instability, there is some posterior instability when you compare it with the normal side. Maybe there is pain, maybe there is no pain. That is one where I mentally made up that I might have to do here posterior inferior glenoid ligament fixation. And when there is a very lax joint, capacious axillary pouch, and posterior inferior glenohumeral ligament is slightly indistinct. There may be a labral lesion or not. That is why that is where I use my posterior inferior glenohumeral ligament tightening. And this is the one such video. Right now, this is anterior superior wing portal. This is the anterior side. Now we are going to the posterior side there. And I was telling that this particular posterior bend does not look very robust, as you can see here. But as soon as you pick it and palpate and tighten, it becomes slightly tight, as you can see with my. You see that?
Yeah.
And there was huge inferior recess. There was some posterior problem as well. There was some labral issue as well. So what you do is, looking from the anterior superior portal, bring your rasp into the posterior portal, and then you just refreshen it. You get a punctate bleeding into it, and then get your spectrum or any other suture passer. Use orthocode kind of partially biodegradable suture material. Take a capsular bite. This is pinch and tuck it underneath the labrum. Retrieve it into the mid-glenoid portal. Introduce the orthocode kind of suture from the mid-glenoid portal. Railroad it to the posterior portal. just like that. Again, you can take it back. I'm not using the mattress suture, I'm using the figure of 4 suture. So I will take that same suture which I have passed through the tissue into the mid-linear portal, take another pinch and tuck underneath the labrum so that I'm plicating the posterior capsule and obliterating the space into the posterior recess. And then I'm coming underneath the labrum, railroading the same suture which has gone through once through the capsular tissue. And then when you retrieve the partner suture, this will form this kind of robust structure, and you tie non-sliding knot. And in this case here, I added one more anchor through the Wilmington portal.
Yeah.
So this concludes my basic step-by-step Bankart's repair. I welcome your comments and discussion.
You can unshare your screen, Sanjay, and then we can have maybe final 5 minutes of discussion, and we can close by 8:30. But this is wonderful. But you depend upon the labrum continuity for your posterior repair like this. And if labrum is not good, you would put an anchor there.
Oh, the webinar ma chupachi karu. Yes. So when labrum is good enough and firmly stuck, I use labrum as a
anchor.
Labrum as an anchor point. But if it is not there, I do not hesitate to put an anchor there and use this. But whenever I'm unhappy, I use this technique. So tightening the when anterior repair is slightly, inferior or very capacious or very hyperlex individual, I would add this posterior, fixation to my Bankart's repair to give that, support to the hammer.
So, but would you do posterior first and then come anterior in such cases?
So what I do is I pass my suture posteriorly first and park it there. But I will not tie them until I have finished my anterior repair.
Sanjay, I've seen a couple of surgeons who actually give a cut into the posterior capsule and try to do what is called as a double breasting kind of thing.
Yes, I have also seen that. But I think this technique is originally described by the Snyder. This posterior, getting a punctate bleeding through the synovium. And I am quite happy with this technique, and I believe that this synovial fluid will stick together along with this partially absorbable suture, so they will not create any long-term issue there with the permanent suture. It is important to note that use PDS or partially dissolving suture in the posterior part.
Using the standard Bankart repair, simple suture or a mattress suture? Because
so for inferior most, I would use a mattress suture, but all other I use simple sutures.
There's a theory that the suture affects the vascularity of the labrum because it is squeezing the labrum. Any takes on it?
There are many laboratory studies, conjectures, and opinions and all. See, in my practice, I use SST principle. Keep it simple, specific, and stupid. That is Trivedi's technique.
Yeah.
Thank you.
It was wonderful. So, are there more questions? Yeah, Ranjit,
yes, Ranjit.
Final question, and then we can conclude.
Yes, Ranjit. Ranjit is asking one question. Yes, Ranjit.
Yeah, regarding the quality of tissue, I would like to ask the panel कि when they decide कि their Bankart repair is not going to work and they have to switch over to a bony procedure.
Can I take that?
Yeah, sure.
Yes.
You have to answer, yes.
Yeah. So, Ranjit, that is unfortunate situation. Most of the time, with the history, number of dislocations, more than 15, 20, you know that this is not fit case for the soft tissue repair. So you kind of know. But when you are in for surprise, my simple policy is to go ahead with the whatever you have planned, come out and explain to the patient that I have done the best which I could do. And if this dislocates, then we have to go for bony procedure, and that we will have to think about whenever it happens. But on table, I have never had any occasion to convert it to the bony procedure. But before doing bony procedure, I have always done arthroscopy. So I think all clinicians should have consulting room deliberation in much details to decide the treatment option with the patient, looking at the history, looking at the MRI, and anticipate all kind of surprises, so that this kind of incidences do not come. Mostly this happens in the traveling scopy, where you carry your instrument and land up somewhere, and you come across this situation, then simply keep your mouth shut and do the job and get out.
So simply speaking, whether to do a soft tissue repair or a Bankart repair is mainly, I think, a pre-op decision based on
Yes, I totally believe in that.
investigations, and then you go.
I think clinical aspect is the most important thing to choose whether how you go ahead, because if you clinically see that how much the patient is going to do the external rotation, and if it is more than like 90, close to 90, and more than going beyond 90 at 0 degree of abduction, then it is a frowning situation for you, because you can know this guy is hyperlax, this is going to be external rotation too much, and better to explain the patient the outcome beforehand, because it is very difficult to convert unless and otherwise you have got the consent of doing it.
So Samanta sir, to tell you the truth, for these people, I always tell them, if you are a sports person, go for bony procedure. If you are a normal Joe, then you go for soft tissue procedure. And there are redislocation rate up to 15% in this kind of situation. And I leave that decision to the patient. I have stopped taking the decision for the patient. I give them option, pros and cons, and let them choose, and that has made my life much easier. Because deciding for the patient is a big responsibility, and sometimes you don't know what is going to happen. But when you give them pros and cons and options and let them choose, that makes surgeon's life simpler.
So one last question. So if you look at the literature of the soft tissue repair, the failure rate varies from like 3% up to about 20, 25, 30%. Oh, how can you account for it? Like such a huge difference in the failure.
So the redislocation rate, which is 15 to 20%, is the old generation papers probably. And technique was not so refined in those times. Number of anchors were defined just 10 years back, actually, that you need to have minimum 3 anchors. So I think currently where we stand, if properly indicated and properly performed procedure, 3 to 5% is the redislocation.
Yes. All the literature is going around 4%. Is the
3 to 5 is the range.
1.5 to 4%. So if you do it, whatever Sanjay sir has told, that if we follow the proper clinical aspect, properly indicated cases, and cases done like what he showed excellently, I think failure rate will be 1.5 to 4% only.
And also, Sanjay, the pick and take technique, which you said, and I think Roshan also said, for poor capsular tissue, you can actually use it as a backup plane in such cases where you can take a tub and then, so I think it is also.
That is also, when I went to SCOI, that is where I learned. That is also Snyder technique. That in the multi-direction, he showed that technique, but it is applicable to all the hyperlax individual, where you can pinch a part of capsule, and it is very easy. Once you have control on this movement, it becomes very easy.
Absolutely. So I think
regarding the assessment of recurrence of the Bankart repair, Dr. Sanjay, which factor you will give importance? Is it age, or is it activity level or sports, or is it Witten score? For you, which is more important?
There is no single factor responsible for that.
Also,
body type is given, you can't change, right? So you have to discount that. The most important thing is number of dislocations before he comes to you. More number of dislocations means his capsular tissue and labrum quality is going to be poorer. So in that case, redislocation rate is obviously very high. Hyperlax individuals, sometimes with the pinch and tuck and your technique, you can overcome. But number of dislocations, you cannot overcome, and the bone loss. So whenever you are in doubt whether this bone loss is adequate for the Bankart's repair, soft tissue, or bony procedure, leave that decision to the patient. Never keep that decision with you. That is my practical advice. Let him choose. I can do this also, I can do that also. You decide. Here it is this, there will be screw, it will be in the joint, this, that, whatever you tell, blah, blah, blah. And this is all, your joint is normal, 2 punctures, this, that, and leave that decision to him. So important thing is quality of tissue, and quality of tissue on MRI, that is number 2. But number 1 is number of dislocations. I'm more scared when number of dislocations go beyond 15, and at 25 I stop. I don't even discuss soft tissue procedures.
Also, one thing is the sleep dislocations. I think it's a high chance of we should always go for bony procedure. If the patient,
I don't consider slip dislocation as a indication for the bony procedure. Slip dislocation in a hyperlex individual with robust labrum is possible. That is just a positional issue in a lax individual. You can very well correct it with the soft tissue procedure. That is my opinion. I think slip dislocation is the one when patient comes to you in your clinic that, sir, ab to kuch karna padega, ab to neend mein bhi ho raha hai.
Yeah. So I think it was
young sportsmen, which procedure you prefer? It's
so there are different sports people.
Say around 1 or 2 dislocations only.
So I tell you, for the contact sports, judo, karate, this, that, football, rugby, though in India there is no rugby, but that kind of contact sports, I would first always do soft tissue procedure.
Soft tissue?
Okay.
Soft tissue procedure.
Only soft tissue.
First soft tissue procedure. And if they recur after soft tissue, I'll offer the bony procedure. And for normal, I do only soft tissue procedure. So to short answer to your question is, when there are 1 or 2 dislocations and all criteria are equal, even if they are sports people, there is no harm in doing the soft tissue procedure. With the rider that you will have a little high dislocation rate, right? So if it is 20%, your 80% soft tissue procedure is successful, isn't it?
Yes.
So here, Ranjit, you are again taking everything, all responsibility on yourself. I'm telling you, in practice, you transfer that choice to the patient. Patient is the king. Let him choose. Don't offer.
Even in the shoulder severity score by Pascal value, the overhead activity sports and only this thing, this is called very 1 point on that, on the overhead activities and all that. So it is not only the sports. I think completely agree with Sanjay sir that it is the number of dislocations, and second point is the age. Lesser the age, higher is the recurrence. If it is less than 20, the recurrence rate is close to 30% to 50%.
But so Ranjit, that recurrence is not on surgeon.
No.
This is for the patient.
No, that is on the patient factor. I am telling about the patient factor. I think if Sanjay sir is doing, Roshan sir is doing, then it is like more or less 90%, 95%.
That is what I was asking. 17-year basketball player. So the risk of recurrence.
Only once or twice. Tissue is good. It can be repaired back.
It can be repaired, Ranjit. Young individual.
Ranjit is forcing us for the first time dislocator. We are not falling into that trap. We are not falling into the trap because first time dislocator is a big talk. And the thing is that now the consensus is even first time dislocator sports says less than 20 operate on first week. So
maybe in a single line we can take that it is the number of dislocations that decides about the procedure whether you're going for
Ranjit, we are not falling into the trap of first time dislocator. We will organize a separate meeting on that where Ranjit you will be invited, and also our boss like the IPS and Roshan Bhai will be guiding us.
I'm very grateful to the IAS for your patient hearing and giving me this opportunity.
It was good talk, and I think after a long time we had a good discussion. And I must thank Dr. Menon and Sridhar for initiating discussion. Also, very big thank to Dr. Roshan Wade. It has been a long time we've been missing him on the platform, and we would love to have Roshan coming in on the basic educational platform more often. Ranjit,
always
questions. Ranjit, you have always been so supportive of the educational initiatives. Thank you for asking so many questions and initiating discussions. Friends, on 28th of September, we have patellofemoral instability symposium. It's at 5 p.m. Dr. David Dichu, he's from University of Virginia, US. He's divisional head for sports medicine. and associate professor of sports medicine there. Patellofemoral instability, we talked last with Gujarat Orthopedic Society also, and there were still a lot of questions which were unanswered. I think Dr. David is one of the pioneer in patellofemoral instability. So join in on 25th September at 5 p.m. on Indian Arthroscopy Society YouTube channel to listen to Dr. David and his opinion on patellofemoral instability. Thank you all the panelists. Thank you Sanjay for joining it today. And it was indeed a very passionate talk with all inputs from eminent faculty. Bankart is something which requires a lot of experience, and we all have been graduated from early days of a titanium anchor now to a knotless anchor. And this journey and discussions have actually enlightened everybody throughout this 1.5 hours of symposium. Thank you, Samantha, and have a nice day. Thank you.